Good morning, everyone. Welcome to City Life Show. I'm Cliff Krieger, your host. It's Monday, Memorial Day here in May. I'm joined by my co-host, Fruin Kembang, who's zooming in, and we're hoping to have 3 guests zooming in.
They're all here.
They're all here.
I'm trying to add their name. I'm going to pin them all up now, so. Just see.
Cliff, Fru.
We have Dr. Ruth Alma Turkson,
Yeah.
and we have Dr. Ernie Kinninjing. Sorry, I thought that was the screen you were looking at.
Okay, so here we have 6 screens at once. Fru, you're going to introduce the folks, right?
Yes, Cliff.
Okay.
Good morning, everyone. This is a wonderful opportunity, and I'm extremely glad and proud that City Life Show is welcoming the sons and daughters of Africa to share their knowledge of health that will help humanity. And I am really very proud to introduce them. You have Dr. Turkan Okran, Ruth Alma. Dr. Ruth Alma Turkan Okran is a clinical investigator at Beth Israel Deaconess Medical Center and Harvard Medical School. She is a board-certified nurse practitioner with a PhD from Johns Hopkins. She's committed to ethical research, empowering and advocating for marginalized populations. Her interests include social determinants of health, cardiometabolic and kidney disease, and wearable devices among persons of African descent. She uses national data sets and community-engaged research to inform intervention reducing inequalities in cardiometabolic disease. For your information, Dr. Ruth Alma is from Ghana. Dr. Ruth Alma, you're welcome on City Life Show.
Thank you so much for having me.
Okay. And I'd like to introduce Dr. Manka Nkimben. Is from Cameroon. She is a nurse scientist and assistant professor at the University of Minnesota School of Public Health. She received her PhD in nursing from Johns Hopkins School of Nursing, her master's in public health from Boston University School of Public Health, and her Bachelor of Science in Nursing from University of Massachusetts Amherst. She works with communities to develop and test culturally appropriate interventions that can be translated into health policies and clinical practice to improve health and eliminate health inequalities for older adults. Welcome, Dr. Manka Nkimben.
Thank you for having me.
Now, aren't you two related?
Well, the more important point is that she's been on the show before.
Well, you said it, John. I didn't say it. Yes. Dr. Ernie Kinninjing is from Cameroon. Dr. Ernie Kinninjing received his Doctor of Public Health degree from Florida A&M University Institute of Public Health in August 2016. He completed a 2-year postdoctoral training in cancer health disparities at the University of Florida Minority Cancer Research and Training Center. During this period, he also served as the program manager for the National Institute of Health sponsored consortium, Prostate Cancer Transatlantic Consortium, where he collaborated on a number of prostate cancer research studies with scientists in Nigeria, Cameroon, England, and the United States. Dr. Kaninji is currently an associate professor of public health at Georgia College and the State University in Mittsville. He is a behavioral health scientist with expertise in prostate cancer disparities research. His research examines the impact of immigration on prostate cancer outcome among sub-Saharan African immigrants in the United States. Additionally, his research explores the within-group differences in prostate cancer outcomes amongst men of African ancestry. He is the principal investigator for 2 research studies funded by the National Institute of Health and the Department of Defense. Dr. Kaninji, you are welcome on City Life Show.
Delighted to be here. Thank you.
So,
Cliff, over to you.
Okay, thanks. So, Fru's helped me with questions. So we're going to start with Dr. Turkson Okran. Although I do want to say that I was afraid we were going to be overwhelmed by Johns Hopkins University. So I'm glad to see that there's someone besides from a different school to provide a little bit of variety. So, Dr. Turkson Okran, how did you get into the metabolic health research area?
So, thank you so much for that question. I worked as a nurse practitioner in a critical access area in Texas, so in West Texas, Pecos, Texas specifically. Not many people have heard of that part of Texas. And over there, I did see a lot of persons who had either maybe were not adequately covered by health insurance, who were immigrants, but most of them had, varying degrees of cardiovascular and metabolic diseases. And I could tell that there was some sort of disparity among the persons that I did see. And so I got curious about, looking at factors that can essentially improve the health of persons who were minoritized. And I guess specifically coming from Western Africa, I did want to, I did shift my focus from just immigrants in general, who I was seeing in that population, to persons of African descent, so including immigrants. And so that's one of the ways I did see it. So my research is essentially, I still practice as a nurse practitioner, is informed by my clinical practice.
So when I think of Pecos, I don't think of recent African immigrants, although I would understand that Africans who have been in the country for a couple hundred years might be out that way. Do you find many immigrants there?
So Pecos, Texas is about maybe 2 hours away from, east-ish of the Mexican border. And so the immigrants that I did see, there were more Mexican immigrants. But yes, there were some African immigrants out there. Not a lot, very, very few. But I guess what I was seeing was not necessarily unique to, the maybe Mexican immigrants that I did see. And so that's why my interest evolved from just, the immigrants that I was seeing in the West Texas region to include African immigrants.
Can you discuss some of the unique challenges or barriers that you found for individuals of African descent that they're facing maintaining optimal metabolic health
So thank you for that question. So there are a number of factors that in my work with African immigrants specifically, that I guess some of my work that I've noticed is that no, I guess similar to other minoritized populations here in the U.S., we do see that factors concerning social determinants of health also apply. So whether you're talking about income level, talking about maybe health insurance coverage, but they're also very I guess interesting factors. So a lot of times African immigrants to the U.S., the research has shown that are highly educated, and so you do have persons who have, I guess, if you're compared to I guess U.S. persons or U.S. white persons, they tend to have college and degrees and higher. But when you look at income levels, they don't, compared to other populations, they don't necessarily, I guess, match the higher level of education that we also see. And so you see, I guess, Black immigrants who have I guess, advanced degrees, but then you're looking at a level that is not, a level of income that is not as high as you would have expected for that population. There are other African immigrants we've also seen that experience increased levels of, I guess, discrimination, stress here in the U.S. And we've seen that it associated with higher levels of high blood pressure, for example, cholesterol also, for example. So those are, I guess, a couple. I could go on and on, but those are a couple of the things that I have been also seeing. We African immigrants also have a higher level of, I guess, hypertension when you're looking at when you're comparing, I guess, African immigrants compared to your in disparities research, we usually compare them to their risk profile to, I guess, white U.S.-born persons. You see that difference, but then when you're looking specifically among the other I guess, immigrants of African descent, whether it's Afro-Caribbean or African Americans, we do see that African immigrants have a healthier cardiovascular risk profile. So they have less, I guess, the prevalence of hypertension, diabetes, overweight, obesity is less among African immigrants compared to African Americans, for example.
Yeah,
and then you have Afro-Caribbeans in the middle of the two groups.
Lowell may be somewhat unique with a higher proportion of African immigrants than native U.S.-born African Americans. But I noticed that during COVID-19, the percentage of people getting COVID was lower in the Black community in Lowell than it was in other communities. So do you think this is genetic, or is this due to cultural experiences they brought with them from Africa?
I guess when you're talking about genetics, I don't yet know of any, I guess, really significant differences that could, I guess, have factored in. But a lot of times we need, especially in the context of the pandemic, we do need to consider, I guess, environmental factors that environmental factors that may have had a role in what we saw. A lot of times when we have, I guess, immigrants tend to live in enclaves. So you are drawn to where your people are, essentially, and that's how health information and other things is passed down from, is passed around. And so depending on how strong of a tie you have to your community, that tends to essentially, I guess, offer some kind of protective, I guess, some kind of protection against some of, I guess, maybe adverse factors, and this may have included, I guess, what we saw with the pandemic. Again, I don't necessarily, and Dr. Nkimbeng might also have some maybe more insight on this, but as far as I know, I was not involved in specific studies that could have, I guess, specifically shown light to this. But again, I do know that there is a lot of, I guess, immigrants, African immigrants in the area, and I guess we did see what we did. We did see, I guess, some difference compared to other areas of the state, of the country, for even.
Right. So, based on your research findings, what practical recommendations or lifestyle interventions would you suggest to individuals of African descent to improve their cardiovascular health outcome?
I would say that some of the recommendations might seem, I guess, similar to what we would also give to other persons from, other backgrounds, and that involves, I guess, things that concern lifestyle changes. And so whether it is, eating healthy, we know that, and when we're talking specifically about eating healthy, there are certain eating patterns that have been proven to offer I guess, improved or better cardiovascular disease risk profile. So we hear of what's known as the DASH diet. So it stands for Dietary Approaches to Stop Hypertension. It's an eating pattern that is higher in fruits and vegetables, lower in saturated fats, and includes lean meats, for example. And we've seen that does improve or decrease the risk of development of hypertension, but also once people have hypertension, we see that also decreases the progression into other adverse outcomes. However, specific to this population, one of the things that we do need to also know, is that you're able to adhere to the DASH eating pattern by still eating foods that are culturally concordant. One of the key things to know in this is portion control, so eating according to the recommended serving sizes, but also watching what other things are included in food. So whether it's sodium additives, sometimes there might be spices that may contain like increased level of sodium that we may not necessarily be aware of. So just kind of looking a little bit deeper into those things, and also improving physical activity. So whether it's, walking more, having a partner to maybe do daily, if you can, walks, but at least about 4 times a week, at least for 30 minutes. That can help you catch up with other people. That can also help also increase your cardiovascular, I guess, resistance, which will improve your overall health and well-being. And so that doesn't only apply to blood pressure, but it also applies to diabetes, also applies to high cholesterol, among other health conditions. and the other one is, yes, continue to rely on your social network, because we do see a lot of benefits when people have that connection. Yeah, so I guess I can go on, but
would you repeat?
That's a very, very interesting question. I think sugar, like every kind of other products out there, is one of those things where you start to think of the origins, the production, but there's a lot of evidence that high sugar is not good for it's a risk factor of a lot of medical conditions such as diabetes related to high sugar and high carb diets. And so it's really thinking about what form of sugar you're eating, because sugar, the white sugar is one form of sugar.
What I'm talking about is just plain old white sugar, the sugar we find in most of our beverages. And also, I've been asked, we have to keep our answers brief, so everybody gets to go around the table here. So please continue. I'm looking at white sugar, the sugar we have in our favorite beverage, and that's what I'm looking to talk about. Thank you.
So as to saying that white sugar causes cancer, I personally am not a cancer expert, so I'm going to toss that over to Dr. Keninjing, but I know excessive sugar, be it in sodas or whatever drinks, is not good for your health because it's related to diabetes and other poor health outcomes. But I'll let Dr. Keninjing take that since he's a cancer expert.
Well, I'll just say sugar and other sweeteners have been shown to be associated with negative health outcomes. In terms of a direct causation, I can't say that. I'll have to double check that. But sweeteners and sugars have been shown to be correlated with adverse health conditions. So I'll go pretty, especially processed white sugar. I'll reduce my intake.
Thank you. Back to you, Cliff.
Okay. So, yeah, I want to thank our first participant, and we're moving on to Dr. Manka Nkimbang, who's from Minnesota. So why are you studying African immigrant older adults? Isn't that kind of a small population?
Thank you so much for that question. I think when we think about equity in research and equity, we want to make sure that we're understanding the health outcomes of every population, even small populations. And one of the reasons why I'm working with primarily African immigrant older adults is that when I was looking into the data to really, as an African immigrant, I was curious to understand the health of the population that I came from. And I went to the literature and I could not see any data on African immigrant health. And at the time, my faculty mentor who at the time was working with me with other older adults, who were doing a lot of work with the African American older adults in Baltimore, with the white older adults in Baltimore, and I was looking to see what was happening with African immigrants. And she's like, if there's no data, whose responsibility is it to get the data? So basically, there was no data for that population. And so I think it's very important that we study and understand the health risk factors of all populations. And so that's why I'm doing African immigrants, because we do not have any work or data on that population. And it's important that we do for every race or ethnicity in the United States.
So what advice would you give for health? We already heard from your colleague that 30-minute walk 3 times a week is good for you. What suggestion would you have for the audience?
So definitely 30-minute walk is good for you, and whatever is good for your heart is good for your brain. So my primary area of study is cognitive function and dementia. So everything that you would do that Dr. Turkson Okran talked about for your heart is good for your brain. But adding on to some of the things she talked about, staying away from the tobacco and the smoking, making sure that you're staying away from air pollution. For those who have some sort of hearing impairment, getting it treated, or for those who do not have it, preventing hearing loss, really thinking about educating yourself and preventing health injuries. Those are some of the risk factors of cognitive function. And then also being connected, social connection, because social isolation is a risk factor for dementia. So you want to hang out with your friends. I know John was talking a little bit about the parade that was happening today. That's one way of staying connected and going out to hang out with friends. So that social connection is very important because it also prevents cognitive impairment and dementias.
I've been told stop asking questions. There's a script, so I'm going to turn it over to Cliff.
You mentioned dementia a couple times. Why is this a major concern for older adults?
Yes, that's a great question. So dementia, let me first talk about what dementia is, because I think that's the other piece of the puzzle that we need to talk through. So dementia, it's a medical condition that is associated with cognitive decline that affects function. And so it affects you doing your day-to-day activities. So people who have cognitive decline in such a way that they're no longer able to do their daily activities. Daily activities include brushing your teeth, bathing, showering, cooking, managing your medications, managing your money. So once your cognitive function is so impaired that you're no longer able to do these activities, technically we say that you might have some sort of dementia. And dementia is an umbrella term. There's different causes of dementia. So there's the Alzheimer's type dementia, there's the Lewy body type dementia, there's the frontotemporal type of dementia. So this kind of group of conditions are really prevalent after the age of 65. So that's one of the reasons why we really think about it. And there's been growing evidence to show that there's a lot of things that we can do, especially midlife, to prevent it. So it's one of those conditions that although we currently do not have a cure, there's a lot of treatment for it, but also there's a lot that we can do to prevent it. So it's really important that, especially in the midlife, we start doing some of the things that Dr. Turkson Okran and I have talked about, in addition to staying away from the sugars, because those are all risk factors of dementia that can affect you as you age.
What are some of the other factors that you think cause dementia?
So basically, when you think of dementia, what is happening in the brain is that there's a brain cell dead in the brain. And so wherever the brain cell damage happens, then the symptoms that you might perceive are related to that brain cell death. So there's so many things that can cause brain cell death. And like we're talking about in the different types of dementia, it's talking about where the brain cell death is happening. So in the Alzheimer's type of dementia, there's an accumulation of plaques and proteins in the brain that is causing brain cell death, and then is affecting the function that a person can exhibit. So really, there's so many things that can put you at risk for brain cell death. And so what is causing symptoms is the brain cell death in your brain. But as we're talking about, there's a lot of things that can put you at risk for it. And so hypertension is a risk factor. Head injury is a risk factor. Some of the cardiovascular disease, diabetes, hypertension, hearing impairment, obesity, and all of those things are risk factors that can put you on a poor trajectory to then having some sort of issues in the brain.
Before we go back over to Cliff, I'm going to ask you girls or ask the three of you guys, with dementia, is there, I see a lot of my old-timer friends, they play this Sudoku game on their iPad. They have these mind games they play. Are those helpful in preventing Alzheimer's? And then we're going back to Cliff with the script.
Yes, that's a really great question. Yes, Sudoku and those kind of mind games and other strategy games that you do that really cause your brain to think and work have been proven to fend off the issues that might happen as you age. So yes, we recommend doing Sudoku, doing exercise, eating well, sleeping well, in addition to all of those things. Strategy games really are the things that have been shown to improve health. And there's also evidence showing that if you can add a mental game and physical activity at the same time, that can help you. So people who are doing Sudoku while walking or whatever you're doing, if you're doing something physical and something mental at the same time, that is really also good for your brain health. So
back over to Cliff.
Okay, so you mentioned earlier the dearth of statistics on African immigrants. as you've gotten into this, have you found that the population of recent immigrants from Africa, let's say the last 50, 60, 70 years, does that population deviate from the standard U.S. population or the standard U.S. black population in terms of things like dementia and other health outcomes?
So that's a really great question that it's a little complex to answer, but I'll try to talk in simpler terms. So when it comes to dementia, what we're finding is that we don't have really great studies that study the current burden of the problem. So there's no national study that can say this is the number of black immigrants that have dementia. But what we have is this small pockets of studies that have been done, and many of them are saying that when you compare the rates of the condition to those of the African Americans or persons who were descendants of slaves, their burden might be a little bit lower, but when you're comparing to the white population, it might be higher, which is similar to what Dr. Turkson Okran was talking about with the cardiovascular disease risk. But the bigger problem we have with the immigrant communities that I have observed in practice is the limited education. So a lot of people in the community do not know and do not use the term dementia. So we find that if there's no understanding of a medical condition, then it's almost difficult to measure who has that medical condition. And so a lot of the work that I've been doing right now is actually doing that first step of educating people as to what is dementia, what are the signs and symptoms, and then what do you do if you recognize any of the signs and symptoms in your relative. I believe it's in this work of educating and then informing that then leads to diagnosis that we're hoping that in the next couple of years we can get decent estimates of what are the numbers of persons of African descent or African immigrants that actually have dementia, and how can we look at it now in relationship to the other groups in the United States.
Got a question from the audience, actually two issues, and they're asking, puzzles, the statement puzzles is another good thing for the brain. And good morning, how about from sports concussions? Could you speak to those issues? Thank you. Sports concussions.
Thank you. That's a great question. So typically, sports concussions are tied into the group of traumatic brain injury, and that's a risk factor for dementia. So that's been a shown risk factor for dementia. Yeah.
Thank you. Back to
and
go ahead.
And the puzzles we're talking about, any kind of games that can really get you to strategize with your mind are very helpful. So if you're playing puzzles that include really those kind of technical pieces to strategy, that's good.
The dementia strikes me as having a big family effect. I had a good friend from when I was living in Naples, Italy, and he, very bright man. He got early onset Alzheimer's in his 50s, and his wife, Carol, one time said that she would never be able to deal with that again. So she's never remarried. I don't know why she hasn't remarried, but my sense is that she's trying to keep her distance from that kind of a problem. Do we see that very much?
Yes, so there is a certain component of different types of dementias that are familial, so that there's a family history, especially for those that you're talking about that express themselves early, the early onset dementias. So there is some familiar risk factor, but I would also say that just because you have kind of a family history does not mean that you're going to have it. And really, that's a point where we would encourage that people engage in a lot of the preventative activities. Family history does not equal to having it. Family history just means you have a higher risk of having it, but that's not a guarantee. So there's still a lot that is within the person's control to be able to do all of the work to prevent it, staying healthy, eating, exercising, and doing all of that stuff. But yes, there's a familiar risk factor for dementia.
Okay, thank you very much. And our third panelist, Dr. Kninjing. So how's the weather down there in Georgia?
Well, it's nice. It's kind of overcast right now. We got some rains over the weekend, but we're expecting a high in the 80s today.
Oh, well, I hope the air conditioner is working. So your area is men's health. What got you interested in that as a specialization?
Well, one key reason is the fact that men are at a higher risk for many serious health conditions and problems when you compare to women. So, for example, heart disease, lung cancer. Now, did you know that men die an average of 5 years earlier than women? So think about that. So, in other words, if you take a look at the life expectancy in the United States, if you take a look at the figures that the CDC publishes, you notice that the average life expectancy for a woman in the United States is 80.2 years. When you compare that to a man, it's just 74.8. Now, additionally, men do face some unique health problems that do not affect women, like, for instance, prostate cancer. So my interest and research about men's health is really to raise awareness about these health outcomes. But importantly, to share ideas about proactive actions that men could take to mitigate or at least to limit, the negative health outcomes that they currently experience. So to answer your question, the focus of my research is to empower men to take an active role in their health and also in the health of their families.
Okay, so risk factors that negatively impact men's health. What are some of the main risk factors in your mind?
Well, we could put that in two big buckets. The first bucket would be stuff that is within your control, and then there's also stuff that is out of your control. So, for example, out of your control, talk about genetics, your genes, your DNA, what you inherit from your parents. So, for example, a family history of prostate cancer means that you are at a higher risk, elevated risk. So if you're a first-degree relative, your father, your brother had prostate cancer, that means you're at a higher risk, all right? Also, if you're black, of black ancestry, all right, you are also at a higher risk. That also speaks to the genetic component of this. Secondly, your age, all right? The older we get, the higher our likelihood of getting some diseases, including cancer. Now, having said that, let me say a few diseases or few conditions are purely attributed to genetic factors. So in most cases, we're talking of interactions between genetics and environmental factors. So I haven't talked about two things that you don't have control over, like your genes or your age or your family history. Let's talk about what you have control over, which is behavioral risk factors. These behavioral risk factors I'm going to mention here, you've heard them already by our two other panelists, all right? What can you control? Tobacco and smoke exposure, whether you're smoking or you're inhaling, has been actually shown to cause. So in those cases, tobacco causes cancer. Lung cancer, for example, has been proven without a doubt. Other risk factors, behavioral risk factors, would include alcohol use and misuse, physical inactivity or just leading a sedentary lifestyle, nutrition, diet, and obesity. So those are all factors. Now, I just want to hasten to add that there are some factors that are beyond the control of an individual. We'll talk about structural factors. For example, lack of access to health insurance. Without health insurance, you cannot go see the doctor. Without going see the doctor, you cannot be proactive about your own health. So in as much as we're talking about these individual level factors, we also have to keep in mind that there are some structural factors that may be beyond the control of an individual.
Is, in your studies, have you found, is there a disparity in the population versus medical density? I mean, I consider myself lucky living up here because there's Boston and all that good medical facility down there. But out across, say, the back areas of Georgia, do we find that there is not a sufficient concentration of medical people?
Absolutely. So you're hinting at some of those structural factors that we have to address. How do we make sure that somebody living in a rural area doesn't have the barrier, the roadblocks of having to drive to Emory or having to drive to Atlanta? Or similarly, people in more rural areas in Massachusetts, how do we take care of those remove those barriers to make sure that they have adequate access to care? So what you're hinting at are some important structural factors. So we still have higher incidence of prostate cancer in urban and rural areas. But the trouble is people in rural areas have to make their way to these tertiary hospitals where there is more advanced care for them. So removing those barriers, for example, people taking treatment, chemotherapy may need to go 3, 4, 5 times a week. So are we providing them with the required transportation to go do that? When they come back, they have to rest. Are we putting them in a hotel, for example, closer to where their treatment are? So those are some key barriers, disparity that comes about just because of your geographic location. The fact that you're in a rural area doesn't mean you shouldn't have access to care that people in urban areas have.
I've got another question in this area, and then the producer has a question. But and since we have 2 nurse practitioner qualified people here, maybe we'll look for 3 answers. But my next door neighbor is a nurse practitioner, and she claims that nurse practitioners are probably better at doing diagnosis than medical doctors. Is nurse practitioners and physician's assistants, is this a good way of spreading out our medical capabilities in the country?
Let me go first, and the nurse practitioners will follow suit. But there are important components. They work together as a team. There are important components. Sometimes they do spend more time with their patients, so they do get to know their patients pretty well. But when it comes to diagnosis for the cancers that I work with, we do need to make sure that we have laboratory tests that can positively confirm, and then treatment will go on from there. But the nurse practitioners are critical because they do spend more time. They can get to know people's family history. They can actually recommend some screening earlier than some practitioners, because just the nature of their work, they don't get to spend as much time with the patients as the next practitioner might. But for diagnosis, we do need a lab test that could definitively say yeah or nay.
Yeah, and the 2 experts, any thoughts?
I totally agree with Dr. Kininjing. Nurse practitioners are one of, the parts of the medical team. And so I think healthcare cannot exist efficiently, effectively without, collaboration of other members of the healthcare team. Yes, we have, there are some studies that show, I guess, both sides. But yes, there are some studies that have shown that, working with a nurse practitioner, nurse practitioners, because of the background, you have to be a nurse first and then get advanced training to become a nurse practitioner. And so drawing on that background of nursing and being able to tease that information out, observation and other things that maybe some other, members of the healthcare team may not have had exposure to, does seem to, help. And maybe also the ways that, information is drawn out of people just to get people to talk might also be a little different too. And so those are, some of the benefits of having nurse practitioners be part of the team. And any other, input from you, Dr. Kimbing?
I echo what the 2 panelists have mentioned, and I would just add, I think we've heard recently that a lot of nurse practitioners are practicing in this kind of critical access areas, but the moral of the story is that there are different types of expertise, and we need all of them, and there's a shortage in all across the board in physicians, nurse practitioners, and nurses. So we need everyone to come to the table to get equitable care across race and ethnicity, across geography. We need all of the experts in the room, and we just need more of all of them right now. So,
okay, John, you had a question.
Yeah. See, as as a grandparent, I'm a champion in taking my grandkids for ice cream to McDonald's. That's where I'm a champion of taking them to those places, and they absolutely love it. And that's a grandparent's privilege. What do you think parents should do about the overconsumption of fast food when it comes to a little one? And if 30 seconds, if you could just keep your answer to 30 seconds, and I'll start off with one with you got the biggest smile, so I'm going to say, Dr. Ruth, if you could give me your, and then we'll go to Dr. Manka, and then we'll go to Dr. Ernie.
I have a question too.
Yes, absolutely. So one of the biggest things I tell parents is that if you do not purchase it, it wouldn't be in the house to be available for consumption. And so one of the biggest things is, who is doing the purchasing of foods in the home, and just kind of, I guess, directing education to that person, or support to that person, so that they can purchase or make choices that are healthier for the family. So I think that's absolutely where it starts from. And so if there's no Oreos at home, for example, and instead there are maybe oranges, you're more likely to snack on a fruit, for example.
Oranges are better than Oreos. Oranges are better than Oreos.
Right.
Okay, so Dr. Manka?
So I think there's quite a few reasons why some people might be going to fast foods. And so it's really just rethinking and thinking about food as what food is. I think for us, the Africans, food is part of culture. And so even if it wasn't culture that you grew up with as in your household, parents can make it a new culture. It could be that cooking food is now part of your new culture or in your family. And so thinking about how you make healthy eating as part of your lifestyle and not just this one-off thing, and really taking a step back to think about, if this is our lifestyle in the family, how do we achieve it? Is it that we are cooking after homework at home with the kids? We all get into the kitchen and cook, and that makes it more fun for everyone involved. Food that we've all been actively taking part in preparing, it's often more fun to eat than just, not being part of it. So really it's just doing some different types of lifestyle things and restructuring of our lifestyles and families in a way that supports healthy eating is important.
Thank you. Dr. Ernie, what are your thoughts on for a healthy choice for parents, not grandparents? We can still get away with murder.
Yeah, I'll just say quickly, behaviors are pretty easy to form, but it can be very challenging to change. And so watch, how much you're exposing them to some of that, salty diet, high in sodium, because once the palates get used to those, it becomes a very big challenge later on in life. Importantly, also making sure they are physically active. It's okay once in a while for that birthday, have that ice cream, but also making sure they go to the park, they can play it off, they can, exercise and burn some of those calories.
Thank you, Doctor. Back to Cliff. Oh,
Okay,
no,
Fru has a question.
Oh, yes, thank you, Cliff. I'm very proud of our panelists. Picture in your mind that you are speaking to African health care, and our parents and our mothers back in the continent. And I'm so proud that you have chosen to talk about these specialties that you have embarked on, and you rightly said that no one took care of. There was no data, no information, and you took that challenge upon yourself because you want to serve, you want to provide information where there is a lot of need and there's no information. Talk to our parents, sisters, brothers back in Africa who are in the medical care and who are also in need of how they can change their mental health. Please, all of you can share it in your own, from your own perspective and speak to them.
So let me go first, because this is an area that is near and dear to my heart, which is reaching men, empowering men to be active in their health. The key thing is for them to be proactive. The men will sit until there is pain, until it becomes unbearable before they're going to go see the doctor. So the one thing, if there's one thing I can do to really implore healthcare practitioners back in Africa when you're dealing with men, is to have them know that it's okay to be vulnerable. If you're sick, go get the care that you need. And don't wait. Don't be proactive about your health. Also, if you get a diagnosis, it's okay to seek a second opinion. Find out what some other experts are saying that before you embark upon a care together with your practitioner. But one quick message I would say for men, be proactive. Go get those screenings, get the PSA, get your blood sugar checked so you know what your baseline numbers are. And you could tell if down the road there are any huge changes from those baseline numbers.
Absolutely. I guess I can also go next, and I guess directly message my messaging specifically to healthcare providers is, in addition to what Dr. Kninjin said, is to also be open and willing to, I guess, newer and different ways of addressing, I guess, healthcare issues. And so there are some methods that I guess over time haven't, I guess, evolved. The ways of diagnosing, for example, methods of treatment. There's new information that comes out all the time, and as so, just kind of, I guess, being open and willing to share. And there's also nothing wrong with saying you don't know, and being open and willing to have, I guess, learn from others. Sometimes we as clinicians also learn from patients, and so that's also one of the things that I would also put out there. There's a lot of times, clinicians on this side are willing to share expertise, knowledge, and other things with people back home. But sometimes we do see a barrier of wanting to maintain the traditional ways of doing things, even though there are other ways of tackling the same problem.
Yes, I echo what the other two panelists have said, and I want to add, especially in relation to dementia and cognitive function, is that there is so much stigma, actually, in Africa and the African continent and many developing countries. There's a lot of stigma around dementia. And one of the challenges is that the healthcare practitioners themselves are not aware of what dementia is. So echoing Dr. Ruth Amatakson a little bit about seeking knowledge and education for yourself, but really for those who are aware of the condition, having a conversation with your patients about it, because the stigma persists because people do not have the right information. And so they just continue perpetrating misinformation. So it's really thinking about every older adult patient you have, even if they have cognitive function issues or not, just having a conversation with them about what is dementia, what are things that are happening related to normal aging versus what is a cognitive impairment that is related to cognitive decline and problems that are related to health. So just having that conversation with patients and communities to decrease the stigma around mental health issues and also cognitive function issues.
Okay. On one of the epitaphs I'm going to put on my gravestone is the word "what," because I can't hear. I say it very often during the. So last year I had a health incident, and they put me on a miracle drug called Jardiance, and that pill is fantastic. Why don't we have a pill for hearing? Is there any research being done where I can take a pill that will? Because a lot of my friends, they're considering an epitaph for their gravestone as well that says "what." So is there something? Is there any research being done that we can take a pill to help with our hearing problems? Don't say what.
I was so tempted. So I guess so far what we've seen, I guess we haven't yet had any kind of magic pill, unfortunately. Hopefully that should be down the, I guess, road in terms of, I guess, scientific development. I think at the moment, one of the things that we, I guess, advocate for is preventative, because there are different kinds of situations that, I guess, that involve our hearing. And so as one gets older, there are different kinds. You get a different kind of hearing loss than, for example, than younger people typically do, and then it's usually at at different ranges. And so I guess just preventative at this point is the best. Recommendation. So whether it's listening to television, I guess for people in their younger ages at a decent level, but also I think something that I typically do, I have a set of reusable hearing earplugs on my keychain, and so I'm just being very, very cognizant about their environment. Sometimes we don't realize that our environments are actually louder than they should be. So just having some of those, for me, I guess, an earplug to put in my ears when I'm in noisy environments, I find has done a wealth of good, because sometimes we don't realize that after being in a loud environment, we do have ringing in the ears, for example. But I'm curious to see what others on here would also.
We're going to continue on Facebook.
We are running out
of
time, but I want to thank Dr. Ruth Alma, Dr. Kaninjing, Dr. Kimben for your wonderful information. And I hope that this is just the beginning, and what you have discussed is very important for our lives. And I believe that our audience will really appreciate you sharing your knowledge and wisdom to us. Cliff, back to you.
Okay. Yes, there's a lot of questions left on the floor in my mind, like a broader discussion of social determinants of health, the issue of Dr. Kaninjing said African men have a higher rate of prostate cancer. Also, from my previous occupation, sickle cell anemia was an issue. Are there other things and other groups that we need to learn about? So still a lot to explore. Thank you all very much for coming.
Thank you.
Thank you for having me.
Thank you.
Thank you for your excellence. God bless. Thanks for coming.
Thank you.
Hope
Enjoy
to see
the
you
rest
next
of your
time.
day.
Thank you.
Bye.
Bye-bye. That was good.
Yeah.